First of all, I want to welcome you, Dr. Allen, to Smith and express our appreciation. Our students have benefited greatly from your writings, and for well over a decade, your text on traumatic relationships and serious mental disorders has been required in this curriculum and has been a major vehicle for our students to learn about the history and treatment of trauma. So my first question, so the ideas you've been working with are based in complex and rigorous research and have yielded very rich understanding about the origins and treatment of relational trauma. And yet the title of your presentation that you're giving tonight is Treating Trauma with Plain Old Therapy. So there is, at least on the surface, a provocative juxtaposition between the rigor of the science you are drawing upon and the term plain old therapy. So could you explain what you mean by plain old therapy and how does it fit with scientific rigor?
In a few sentences. This is not going to be so easy to do. I'm smiling as I'm hearing you talk about this because this never occurred to me. This seeming contradiction between all the complicated research that I refer to routinely and the idea of plain old therapy. So I think what I want to say about it here, and this is actually the gist of what I want to talk about tonight, is that I think we clinicians, and I'm speaking of those out there in private practice, seeing all kinds of patients, doing the best they can to help them in whatever way seems to be most reasonable. We clinicians are haunted by this mainstream evidence-based, we need to be doing evidence-based treatment.
Yeah.
And I can agree with that principle. And actually, okay, if we're talking about evidence-based treatment, we're talking about some kind of scientific research. But what it's come to mean is that you have to have a brand of therapy that is compared either to other brands of therapy or to no therapy, and that your therapy has to work as well or better than some other brand, and hopefully better than nothing at all. That's what the quote evidence base is about. Well, the irony, and I'm generalizing here, but there's a lot of research supporting this, scientific research, ironically. The brand of therapy doesn't make much difference in the outcome.
Yeah.
But you're talking about relational factors, which of course I'm talking about, and there's plenty of evidence that the relationship between the patient and the therapist makes a huge difference. So all I'm saying, when I say plain old therapy, I'm just talking about one person trying to get to know another, trying to understand the other through talking, through conversation. It's not just conversation, there's a kind of emotional bearing that we want to have that enables people to feel comfortable and safe and trusting. A lot of this is beyond words, but what we focus on is our words, the narrative, and trying to come up with a narrative. But my point is that this is talk therapy. I had a patient kind of curmudgeonly, so he sits down and says, "What do you do? Talk therapy?" "Yeah, talk therapy." I said, I just call it plain old therapy because it's the way people relate to each other through making some kind of trusting psychological connection based on a sense of the other person, understanding, and being able to articulate with the person that understanding. So this is plain old therapy. It's plain old relationships, love relationships, friendships. And this goes back, I got to say, to Socrates. This is not new, but trying to think about how best to live. So that's kind of what I call the venerable work that we build on. Now we have a ton of scientific research now that actually helps us understand the nature of these psychologically connected relationships and how things go wrong. So the science really shows, yes, what the plain old everyday therapist in the trenches is doing has tons of evidence to support it. and the brands are not where the action is. So that's, I think, a beginning of an answer to this
Yes.
juxtaposition.
Yes, it certainly is. So my second question is, in a recent paper that was published in the Smith Studies, you used the term biomania to describe your perception that the field of mental health there is now excessive enthusiasm for an exclusively biological approach to psychiatry. And you see biomania as threatening to the humanistic traditions of psychotherapy, which you referred to. And at the same time, you show a very deep appreciation of what you see as the vital contribution of neuroscience
Yes.
to the profession through what you call, and I think this is a wonderful term for everybody to be aware of, science-informed humanism. So how can mental health professions maintain this kind of balanced attention to empirical inquiry and values-informed practice, and what happens to you when you try to advocate for it in your context, which is academic psychiatry?
Yes, right, and a medical school to boot.
Yeah.
Okay, so now you've pinpointed something that I realize. I have mastered the art of speaking out of both sides of my mouth. So, yeah, I find neuroscience really interesting. I know a reasonable amount about it for a plain old therapist. And I do believe, this is a contentious point, but I believe the major advances in psychiatry are going to come from neuroscience.
Yeah.
Because I think this is oversimplifying, but relationships, we can understand them better, but we know what we've got. There's a lot we don't know that's going to come from neuroscience. But that said, my worry about biomania is that it's kind of like the further extension of the evidence-based treatment, that therapy co-opted by scientific technology runs the risk of dehumanizing us.
Yes.
And biomania is kind of on the end of the spectrum. See, we have with the, quote, evidence-based treatments, what you need is a manual to do the therapy. So it makes more and more rule-based, and this is our technology, is our therapy manuals. Well, now we have biological technology, which is fascinating and seductive.
Yeah.
And we've got glorious colored pictures of brain activity and all of this. And it is just wonderful and interesting and so forth. But I can summarize the biomania problem very quickly, if I can stop talking so much.
Oh.
That there's
Please continue.
a ton of interest in the brain, which leaves out the life.
Yes.
And this is my complaint. But what about the life? If you think about heart disease, okay, you've got heart problems. Where does this come from? Well, yes, genetics plays an important role, but how you live your life plays a huge role. And in the treatment of heart disease, how you live your life is fundamental. So why aren't we thinking about this in psychiatry? Well, let's fix your brain. Well, great. But if you don't fix your life, the brain is going to respond accordingly. So it's very simply put, that's my concern and frustration. With brain, I want to see life, and then we've got it.
Right. And that would perhaps be true for medicine as a whole, that the isolation of one organ system inherently disconnects people from examination of a fully lived life.
Yes, exactly. Yep.
Okay, so question 3. You have written about the dynamics of stigma, which is directed by the larger society towards people with significant mental illness. And it has been argued by many that understanding mental illnesses as brain disorders would reduce stigma. In contrast, you assert that perception of mental illness as a brain disorder can augment as well as reduce different kinds of stigma. And can you help us appreciate the complexity of the challenge of reducing stigma through medical and humanistic discourses, which are, again, somewhat different?
Yes. Well, again, an enormous topic. But let me say, this is as an extension of the Biomania issue, because one of my colleagues, thankfully, knowing I'd written about Biomania, sent me an article that was a review of a lot of research on the impact of reframing psychiatric disorders as brain diseases on stigma. There's been quite a lot of research. In fact, this is many thousand participants in the whole set of studies. What was shocking to me, and I've been teaching patients about, you need to understand that this is physical. Depression, this is a physical illness. PTSD, these are indeed physical illnesses. There's a ton of evidence for this. Now, Zoss, you remember Zoss wrote this with the myth of mental illness?
Yes.
And
He was banned from Massachusetts Mental Health Center when I was working there, yes.
Yeah. So mental illness is no myth, but Zoss, like me, I appreciate Zoss now, was emphasizing the life. That was kind of a digression, but okay.
Yeah.
So the thing is, I too had bought into that. So I was shocked when I saw this research showing that actually reframing psychiatric disorders as brain diseases not only does not decrease stigma, it actually may increase it.
Yeah.
For example, there's some likelihood that it increases perceived dangerousness, which is a huge contemporary issue now. But it does not actually decrease the stigma. So this is surprising research. If we think, well, it's sort of like, okay, look, this isn't your fault, you know, it's your brain. Well, we don't want to blame people for anything. Blame is the problem. But reframing it as physical actually doesn't. It does actually decrease blame, but it doesn't decrease the kind of social rejection.
Yes.
That's the key issue, and it may in some ways increase it. Now, the chairman, John Oldham, our chief of staff, he and I went around on this, and he made a very good point. He said, well, okay, the problem may not be this reframing. The problem is stigma and how embedded it is in our society. And, you know, he used the idea of cancer. Well, okay, cancer was stigmatized, and it's taken years and years and years of work. And so he kind of said, well, look, don't blame it on reframing it as brain disorders. This is a long-term project. And I think that kind of tempers my concern about it. But we shouldn't think that we're sort of helping stigma by just reframing as brain disorders. Research doesn't support it.
Yeah. Okay, so now we switch to a very different topic. You shared in a blog posting some of your insights about psychotherapy derived from your experience as a jazz composer and pianist. What would you like to share about the meaning of your experience with jazz for deepening the understanding of plain old therapy? Any thoughts about the creative arts in general for psychotherapists?
Wow, you keep expanding the frame here. let me talk just more specifically about jazz. And our son Clifford is a jazz. He's a jazz historian and knows more about jazz than I ever will. But he and I got into a debate about improvising, and anyway, this led me to start thinking about, well, okay, improvisation, now that's interesting. So what about psychotherapy and jazz? And you see, it's the same obsession I have that I've been talking about, that it's a protest against the manualization of treatment, as if we could somehow solve the therapist's anxiety about how to help another suffering person by giving the therapist an algorithm, a manual, and so forth. And I learned very early in my practice, as I'll talk about more tonight, that, you know, a manual is just not going to do the job, and that we have to improvise. And I think improvising it's wonderful, it's creative, it's what we need to be doing, but it's also fraught with anxiety because you never know where you're going.
Right.
And I think this is true for a musician as well. I mean, I love classical music, but there's a script. Well, jazz, there's a bit of a script, but there's a lot of improvisation. And so my thought is that the manuals are a kind of way of getting the therapist off the hook with regard to improvisation. And I think we need to become comfortable with improvisation. And I think that it's mostly improvised, even if you are using a manual.
Great. Thank you. So we've got one last question.
All right.
So as the evidence about the intergenerational impact of relational trauma becomes more known through research, what are the implications for other methods of intervention, including group, family, and community?
Okay, well, thank you for this question. I've spent my entire career pretty much as a clinical psychologist doing individual therapy and related work. And I have no doubt, and we have lots of evidence that individual therapy of various sorts helps people, no doubt about it. But I have concluded, particularly thinking about the infant research in attachment, but attachment research more generally, and this is not new news, certainly to social workers. I mean, this goes back to Bowen, that we are kind of, individual therapy is kind of indirect. Yeah. Because you're helping the person with relationships with the hope that this is going to help with their other, quote, real world relationships. I think a serious problem with therapy is that people get stuck in the therapy relationship as their key relationship.
Absolutely.
Something has gone wrong with the therapy. Yes. It needs to be a bridge to other relationships. And I think it may be a way that people can kind of start on the process of improving their other relationships. But I really think this is what Murray Bowen said a long time ago: work on the relationships directly, their current relationships, the ones that matter in their life, work on them. And I think the attachment research, as I read it, the most hopeful thing in our entire literature is the benefit of early work on early parent-child relationships, coaching, learning, groups of moms and dads to the extent that they'll do it, working together, watching each other interact with their babies, looking at videotapes, and really finding ways of making the connection and repairing disruptions in connections. That's where all the action is. Yes. Relationships aren't about wonderful synchrony. Yeah. It's a romantic illusion. They're about repairing things when they go wrong, which they always do. Mm-hmm. And so helping parents and their youngsters do that. Selma Freiberg, of course, this is like just absolutely brilliant, genius work. Yes. I think this is where the action is, and that we ought to go straight to it. So now I'm ready to retire, and having done my indirect work, I leave it to the people like you who just go right where the action is. Well,
Yes, Ghosts in the Nursery is a beloved text here. And that's Selma Freiberg, and our alumni will recognize that text entirely. It's one of the foundational texts of the school. So it's wonderful to conclude on that note and that shared interest. And I'm so happy to hear you really endorse greater work with families, early work in the relationships between parents and children, sometimes in group context, sometimes in family context, as really, really important to prevent these derailed attachments, which we now know are to some extent intergenerationally transmitted.
Thank you.
Thank you very much.